Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Meghan Gaffney, Chief Executive Officer and Co-Founder of Veda. Meghan, welcome to the show.
Thanks so much for having me.
So, Meghan, what I always like to do before getting into the main part of the discussion is to give my guests more of a chance to provide an introduction in terms of who they are and what they do. So, Meghan, the floor is yours.
Sure. So I lead Veda. We are an AI and machine learning company that helps automate and curate provider information for health plans and large health systems. And my background is in the policy space. So my interest in this topic came from my work in and around the Hill as the Affordable Care Act was being crafted and the importance that provider data has in access to care.
So kind of with that background, what first got you into healthcare? Was it something you always intended to pursue, or did you just fall into it by happenstance?
I think we all fell into it by happenstance as the Affordable Care Act became the topic of the day in Washington, D.C. and around the country. We all had to get smart on healthcare very quickly. And there's an old saying in Washington, D.C., every week is infrastructure week, but that just wasn't true when we were talking about healthcare. And so as I was working with senior appropriators in the House of Representatives, who are clients of mine, I had the opportunity to sit in the room with leaders from health plans and hospital presidents, but also patient advocacy organizations and people concerned about the future of Medicaid and Medicare. And I learned very quickly that there were things that government was going to do to make access to care better, and there were things that just weren't on the table. And this kind of data infrastructure around what the ecosystem of providers and medical facilities looks like and getting that information in the hands of patients wasn't going to be something that government tackled. And I've always had kind of an entrepreneurial mindset. And so I sought out to solve that problem first for myself as a parent who was trying to navigate the system and now largely in the market.
So kind of as you said, you saw that opportunity for a piece of the infrastructure that needed to be created. And you've talked about kind of provider information, provider data already. What do you actually mean when you're talking about that provider info?
Yeah, I mean, for most of us as patients, if we put our patient hat on, the place where we enter the care continuum is when we're looking for a doctor, right? We know, hey, I moved to a new area, I need a new primary care professional, or I got referred out to a dermatologist by my PCP. Now I need to go find one that's in network for my health plan. Getting that information quickly, whether it's through the health plan's website or calling a call center, it is critical for folks to actually start the care process. And what we found and what CMS has found over the years is that about half of the information that's patient-facing is wrong. What that means for people like me, I'm lucky. I have a lot of access to technology. I have time during the day. I'm only working one job. It's a nuisance, perhaps, to make 15 or 20 phone calls until I find a PCP for my kid that's taking new patients now. But if you have a chronic health condition or you have low access to technology, maybe you're a caregiver for a child that needs some specialized medical treatment, it can actually be a barrier to care. And it drives up healthcare costs, but it also is one of the things that is the most impactful for a patient. They can articulate, hey, this is a problem for me. And so we were hearing those conversations as the ACA was being crafted. Yeah, all of this access to care and value-based care is great, but I can't even get an appointment to get in the front door. Value-based care doesn't matter to me yet. But it wasn't being tackled in the legislative process to really think about why is this data so wrong in the first place and how do we fix it for patients to be able to step their foot into the healthcare system and start this care journey. And so that's where the kind of beginning of Veda came from, is I was going through that process with my new daughter. At the same time I was sitting in these meetings, I couldn't figure out how to get her to a pediatric specialist in the capital of the United States, being in all of these rooms with all of the access to information I had, I couldn't find somebody who could treat what she needed at that time. And so out of that frustration, I'm now working to solve this problem for patients across the spectrum.
And kind of that reference, as you said, of roughly half the data being incorrect, can you provide some examples of what is commonly incorrect, and what's the root cause of it being incorrect?
Yeah, I think it's not surprising what's wrong. It's the simple things, right? Is this person actually accepting new patients? You see a provider, great, they're in network for the health plan. You call, it says they're accepting new patients, and nope, they can't see you until next year. Well, that's not really accepting new patients. You can't really get in the door and start your process of getting care. Also, where they're taking patients, the address of the provider. And that can be particularly challenging for folks in the Medicaid system. If you think about, they get automatically assigned a PCP. And if the PCP data is incorrect about where in a large city they practice, say Chicago, it's just down the road from us here in Madison. If you're on the South Side and your PCP looks like they have offices all over the city, one in your neighborhood, one in the north side of town, one in the West Loop, it might be fine. But when you get assigned that PCP and it turns out they closed their office on the south side of town, and now you're assigned to a PCP that it's going to take an hour taking public transit to get there, you're probably not going to go. And then the final thing is the contact information and specialty information, all of those secondary pieces of how do you get them on the phone to make an appointment? Are they the right kind of specialist to treat you? I like to use orthopedic surgery as an example. You don't really have an orthopedic surgeon holistically. You have a hand surgeon or an elbow surgeon or a back surgeon. And so having that information correct is really what patients need to navigate. Why it's wrong is a little more complex, but it comes down to a few things. One, the data actually changes really rapidly. We all know there's been a ton of M&A in healthcare. Offices are being bought by large health systems. They're changing ownership. They're shutting down. Rural offices, rural clinics are closing every day. The data is shifting, but it also shifts in the normal course of business for things like residency changes, right? People are going in and out of residency and private practice on an annual basis. So there's this movement in the data that needs infrastructure that can move it between the provider and the health plan in real time. And then there's an inconsistency. We're in 50 states. We've got a private healthcare system that doesn't require standardization. And frankly, from my time in government, trying to get 50 states and hundreds of thousands of people to actually choose to do something in the same way is a pretty impossible task. So we needed technology to be able to bridge that gap and do the translation of data and help it move in real time in order to get this answer from 50% to as close to 100% right as we can.
Yeah, and maybe this will start getting into how you're helping to improve the infrastructure. But historically, how was the information collected? And I am anticipating that it's going to be a very manual process, and that's part of why you wouldn't be able to keep up with the rapid pace of change that you were just describing.
That's right. I mean, it is largely finally not faxes, but when we started this process, 7-8 years ago, they were faxing data between a provider office and a health plan. Today, it's largely done over email, but it's spreadsheets moving back and forth and people at computer terminals on either side of that communication, hand keying it into downstream systems. So if you think about at a hospital or a clinic, you have somebody who is hand keying information from EMRs and their provider data management systems into a spreadsheet. They send that out to the 20 health plans that they work with via email. And then in each one of those health plans, you have people that are keying that information into their claims, their provider data management, their referral systems. So it takes a long time for that work manually to happen. But if you think about how many keystrokes take place, the opportunity for human error is massive in that process. And so that's really, it compounded the problem of how long it took by how many people are touching the data along the way.
Yeah, and kind of given that, the large scope of manual process that you just described, like who is responsible for ensuring that the data is transmitted? Is it does it rest with the payer, with the clinical organization, both, or kind of where does it fall?
I mean, it depends on who's holding them accountable. From the government's perspective, which is my background, they're really holding the health plans accountable. And the reason why is they're saying, look, you have more money than the provider organizations that you're partnered with. So we're going to put the onus on you to get this right for patients. That's part of your commitment, being a part of this private healthcare system, is that we're not going to have nationalized healthcare, but you have to get some of these simple things right for patients. The relationship between the provider and the plan, though, is complicated. They try to hold each other accountable for getting this information right. I think the challenge is that there's no golden record. There's no source of truth, even within a large provider organization. They have trouble keeping track of this information. And so getting the providers to just give the plan the best data isn't going to solve the problem. And on the plan side, they've thrown their hands up and said over the years to regulators, hey, if the provider can't give us the right information, how are we supposed to know? So it was a really tricky problem that was creating a lot of friction and still creates a lot of friction in that provider and plan relationship.
Yeah, so kind of thinking about that complicated relationship in the current landscape, are there actually existing regulations that set baseline requirements for what information needs to be available, or is that something that's pending?
Yes, it's both. I think the baseline today is that CMS can fine for provider data inaccuracies, and a handful of state Medicaid agencies will look at provider data quality as a part of their RFP process. So those regulations, though, haven't been robustly enforced, and they have a lot of outs and kind of opportunities for folks to get around the rules. The reason, I think, is that there wasn't a good understanding in government of the impact of this problem on people's access to care before COVID. And government focused on network adequacy, but they weren't checking the accuracy of the information. They wanted health plans to be robust in how many providers they contracted with. And they were checking to see, hey, are these contracts in place? Does the health plan say that they have enough providers? But what they weren't checking is that information right? And is the information about where they are actually accurate? And so now you have a shift in thinking after COVID that goes beyond things like the No Surprises Act that we saw a few years ago. You now see legislation in the Real Providers Act that's coming in the Senate, and it has a companion bill in the House, but also a new bill from Senator Tina Smith from Minnesota, which is interesting because United Healthcare's backyard, that applies to commercial health plans for the first time. And it requires a much more robust program that health plans have to have around accuracy, including things like independent audits of data, publishing the data accuracy of their provider directories and networks, doing frequent screening for correctness. And it includes all types of providers, where in the past they focused really on a small subset of specialties, PCPs, oncologists, cardiologists, et cetera. Now it's looking at all providers, and it includes behavioral health. And I think it's really coming to the forefront because patients are complaining and they're mad enough that they're calling their member of Congress. And so we really are seeing a shift that will go into effect starting in 2025 and 26.
Yeah, so that's pointing out, as you said, kind of a lot of upcoming change. And for those of you just joining, I'm talking with Meghan Gaffney from Veda, and we're talking about provider information available to guide, access through payers and participating providers. So Meghan, you just talked about a couple pending bills. So I guess where do those actually stand within Congress? And then probably the $1 million question is, given the current climate in Congress and this year, which is an election year, what are the likelihood of any action actually occurring?
Yeah, I mean, look, Congress can't decide how to order a pizza in a bipartisan way. So you are absolutely right to be skeptical of what this looks like. But I think what's interesting is this is really a bipartisan effort in a way that is pretty unique right now. So the Real Provider Act that you see in the Senate, it's sponsored by Senator Wyden, who is the Democrat, and Senator Crapo, who is the Republican counterpart. They're friends. They collaborate frequently. And that bill came out of the Senate Finance Committee that has a very wide range of partisan flavors on it, from both very far left and very far right, unanimously and with very little markup, which is very interesting and unique. It also has a companion bill in the House that is led by a physician member on the Republican side and Jimmy Panetta on the Democratic side. So you have a Republican from North Carolina and a Democrat from California bipartisanly putting the same language forward in the House. What we're hearing is that it's likely to pass in lame duck. And it will probably be combined in some way with the Tina Smith commercial healthcare bill, because there are other healthcare provisions that have to get legislation passed before the end of the year. They're set to expire. And so it's likely this will all be wrapped into a package and move forward. But there isn't any sense that it's going to die, which I think is pretty interesting. And it's a good election issue. Unfortunately for health plans, there are customers. We see they're trying every day to get this right. We see the effort they put in, but they're a pretty popular punching bag in an election year. And members are going out and they're campaigning on this. They're campaigning on ghost networks. They're saying, hey, this is a problem we know voters you face. You can't figure out which doctor is in your Medicare Advantage network. That's not good for seniors. We're going to go hold these health plans accountable. So I think there's actually a lot of momentum, and there's similar momentum in the states. So I think we're going to see a lot of news around provider data accountability in the next 6 months.
Yeah, and maybe just backing up one quick step, you mentioned that you anticipate it'll pass in the lame duck session. So if you don't mind, can you just clarify what that means, just in case folks aren't necessarily familiar with it?
No, so it's the time between the election and when the new Congress is sworn in. And so what that means is you have members who have lost or won, the election's over, but they still all have business to do. They have things that they care about that they want to get passed. And so people are sometimes willing to take votes that they wouldn't take during the election season in this lame duck period between November and the beginning of January.
Yeah, and then you also mentioned, kind of the reaction of the payers talking, and I think you mentioned that they are trying very hard to have accurate data. So kind of what is their, to the extent or what's their actual perspective on the bills? And, do they feel that the bills go too far, not far enough, or that they prefer other types of modifications?
I mean, from the conversations I've had generally, I will say, just like many things, there's not a single viewpoint, right? There isn't a kind of industry perspective, which is why you don't see AHIP or other industry organizations going out and lobbying really hard, because it's not the same across payers. What I can say is, and this was public in a press release that we did with Humana. We have a partnership with Humana. I know from their perspective, they see provider data as important to their member experience, that they know it's important to seniors and how they make decisions, and they're making investments in the direction of solving this problem and partnering with companies like ours. And it's not just about regulatory issues. It's about really caring about seniors getting access to care. And we love to partner with companies, particularly in the Medicaid and the Medicare space, that really care about their members, and they care about this data as more than a compliance issue. They know that people will choose their health plan over the competitors if the experience of going to get an appointment is simple and easy. And so those are the plans we like to work with. And, we really value the health plan's role in helping to get this front door more wide open for American families.
That all definitely makes sense. And I guess maybe kind of shifting hats, it's, from your personal perspective, do you kind of, what are your feelings about the bills? And, do you see them supporting kind of the efforts that it sounds like you've been working on for a number of years now, because you recognize the problem before many others did?
Yeah, we are very supportive of the path this legislation is taking. And it's really two things that Veda is excited about. One is it opens the door to technology as a solution to this problem. In the past, CMS and the Health and Human Services Secretary have been able to mandate methodologies to try to get the data right. They say you have to call providers, you have to send them emails. At one time, you had to fax them on a regular basis. Super abrasive, very expensive, and the data now shows it just doesn't work. And so what the new legislation does is actually take that power away from the secretary to say how you have to get the right answer, and allows health plans to leverage new technology like ours that is proven to have much higher levels of accuracy and get the right answer for patients. The other thing that we like is we think it's good for consumers to have information and a choice. And so publishing the accuracy, just like they publish STAR scores, to say, hey, if you choose to work with this health plan, this is how hard it's going to be for you to find a provider. That's information that lets the market really drive here. And so it creates incentives outside of just regulatory incentives around fines, and really lets the market drive towards the plans that are investing in their member experience.
And that raises a really good point. And you've kind of been dancing around it a little bit, but it's, how is the technology actually driving positive change, and kind of what has the technology enabled that can show actual improvements?
Yeah, it's a great question, and I love it. So we use technology, including supervised learning, which is a kind of AI that takes in lots of different sources of information. And in our case, it's provider data. So if you think about claims information, rosters that are coming from provider networks, marketing information that's on their website, every time a provider is kind of keying into an EMR or sending a claim, they're creating data every day in their daily workflow. But supervised learning doesn't require that data to be clean or even very correct. It can help us choose what's good and sift through the information to get to the right answer very quickly and without having to do manual outreach to the provider. So we train the model using very highly curated examples of what right data looks like to find the correct information about providers and facilities. And then we stamp that out every 24 hours and make it available. What that means is that we can get the right answer for where a provider is seeing patients, if they're taking new patients, what their specialties and the conditions they treat, without ever having to bother the provider, because they're creating all this data in the first place. In the past, anywhere from 20 to 40% of providers would never provide the information and respond to the health plan when they ask these questions. Now we can get good answers. And so it allows us to get to greater than 90% accuracy through machine learning and automation. And we just validated that through a study with an independent group called the Erdos Institute. It's made up of academic scientists and researchers at major academic institutions across the US. And they validated that this approach can actually get you to those very high levels of accuracy. And we're excited about it. We're excited about the government's embrace of new technology.
Yeah. So kind of given where the technology currently exists, where do you see, the future development going, and where are some of the areas of opportunity that you might want to focus on?
Yeah. So beyond data accuracy, we are always thinking about this automation of data exchange and where we can expand automated data exchange without either side of the equation having to agree on formats like they do in EDI, right? So rosters we can do today, but provider onboarding, initial enrollment, those are places that are still also very manual workflows that we want to expand. I think the real vision, though, long-term is thinking about when you know each provider, each facility, each practice group, what they treat, where they're accepting patients, you can start to build networks that really serve people in their communities in more tailored ways. So we've spent some time working with health plans, particularly around what networks look like in rural communities. It's different. The needs are different. But if you understand who's willing to travel from an urban area, who has both on-site and telemedicine available, you can create networks that serve the communities that they're in very tailored and cost-effective ways. And so that's where we think the future of this goes, is a better understanding of what people need from their provider networks, and then helping health plans and integrated delivery networks and other organizations build out those systems in ways that serve people very well.
Yeah, so I think, as you're saying, it really could be a vehicle to drive collaboration and coordination, because when you remove the friction of being able to identify who can do what and where, it enables you to actually then start drawing lines and connect the different dots.
Yeah, it also frees up a tremendous amount of money in the system when we're automating all of this infrastructure that was done manually. There's so much work with care coordination and collaboration between providers and health plans that no one has money to accomplish right now. And so as we drive down these administrative costs, we're opening up avenues for driving projects that really change the patient experience in positive ways. And we see both on the plan and the provider side a desire to focus on those things. They just have been bogged down by getting this infrastructure right.
Yeah, and in terms of getting that, I guess maybe the last question, in terms of getting that infrastructure right, have you had to overcome any reluctance to adopting the technology or the other strategies for adopting, and how do you convince folks that this is going to be a positive investment that's going to, sounds like, produce a pretty immediate return?
Sure. I mean, there are always challenges in new technological approaches. I think we faced two that are pretty distinct. One is just adopting technology that's hard to understand, explaining AI and supervised learning and explaining the safeguards and testing methodologies around it is pretty complicated. But we have approached it in a way that, we've tried to be as transparent as possible. We make our data science team and my co-founder, our CTO, available to meet with customers. We walk through and we show them how do we test to make sure that this is accurate and safe and their data is protected. I think that's one we can get over. I mean, we all trust GPS to tell us where to go, and I don't think anybody could really explain how it works on the back of their hand, right? If you've tried it enough times and you've tested it, that Google Maps is better than the printed paper map that you had before. And so that's what we all have adopted. I think the more challenging piece is AI has had an incredibly bad PR campaign as a technology. There have not been enough founders and CEOs talking about how do we do this responsibly? How do we think about security first? How do we safeguard data? And how do we know that we're testing for bias and making choices that aren't going to negatively impact people? And if we had more folks talking about that up front, approaching it in a positive way, and also explaining, hey, this is going to unlock the money and the resources we need to actually care for the almost 400 million people in this country.
Yeah, no, and I think that's a great point. And as we're almost out of time, I have one final question for you, which is, what's your kind of boldest prediction for what might happen in the rest of the year?
Oh, I love this question. I think the rest of the year, this year, we will see a continued focus on the AI and healthcare conversation as we get closer to an election and folks are talking about how does healthcare and technology intersect. I believe, though, that these positive voices will start to be breaking through. And we're hoping that Veda can be one of them, talking about the positive role of technology and how we can do this right for patients and make healthcare really work better for people. So I'm the eternal optimist. I think we're moving in the right direction and we'll start to see momentum towards technology done in a responsible way.
Yeah, no, I really like that positive framing on it. And, as I said, believe it or not, we are already out of time. I want to thank my guest, Meghan Gaffney, for a great conversation today.
Thank you so much.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.